Thank you very much, sir, for your very kind introduction. Very good afternoon to all the chairpersons and all the members, delegates, and senior faculty members and colleagues attending this meeting. Thank you very much to the organizing committee for giving me this opportunity to present this work. So without further ado, the topic that has been given to me is about early cholecystectomy in acute cholecystitis. And this has got something of importance because there has been a bit of a controversy and debate about the definition of what is early in early. And I think in the next few slides, I will try to bring to the attention of the audience what is the current literature on this. I bring greetings from my institution, Maulana Azad Medical College, where, as very rightly said by Dr. Singh, Dr. Rana, I shed off the headship, but I retain my unit. And greetings from that institution. So, early cholecystectomy, in the next few slides, we will go about the definition, the current guidelines that have emerged over the last few years. What are the various controversies? What are the risks? Is there any criteria on who can perform early cholecystectomy? And all of this I will try to base on some solid evidence from literature. So at the outset, I would like to talk about the first major guidelines which came in 2013, which were commonly called as the Tokyo Guidelines of 13, published in the Journal of Hepatobiliary Pancreatic Surgery. And this defined surgery as one which is performed within 72 hours of the onset of symptoms of acute cholecystitis. It was also made a note of that it is not always practical, as majority of the patients present after the 3-day onset of symptoms to the doctors or the surgeons. So this was the important take-home point from 2013. But then we have now the 2018 Tokyo Guidelines, which have been published again in the same journal in the January issue of 2018, where the early cholecystectomy has now been defined as gallbladder surgery, which is performed within 3 to 7 day period of the onset of the symptoms, the first symptoms of pain. And in this, there are two distinct categorizations, one which is within 72-hour period of onset or presentation of admission, and one which is within 1 week, which obviously includes the first 72 hours or 3 days. So the range of period that has been given is any time actually between 0 to 7 days. And they also clearly define delayed cholecystectomy as one which is performed 6 weeks after the initial diagnosis. Now, I would like to mention this paper, which was published in the World Journal of Emergency Surgery on the guidelines on acute calculous cholecystitis, what is known as the WSCS guidelines, where it was mentioned that the patients who come with acute cholecystitis can be classified into 3 types: low risk, moderate risk, and high risk. And the patients with low risk actually are the ones who can go for cholecystectomy. The moderate and the high risk ones can be managed with the other procedures, and those who are unfit should go for the conservative management. So this was not very, very clear. In the Tokyo Guidelines of 2018, however, there are 3 criteria of cholecystitis. The grade 1, which is the mild cholecystitis, is one which can go for early cholecystectomy. There is an option of going for antibiotics and general supportive care in the process of managing the patient for early cholecystectomy. And this is the group which has absolutely no controversy. However, the grade 2, which is the moderate symptoms, which are the patient has got more sick, where antibiotics and general supportive care is the first line of treatment in any case. They cannot go to the surgery straight away. In this, there were three different pathways. One was where the patients went for a delayed or an elective laparoscopic cholecystectomy. The other, which was they went to the urgent or early gallbladder drainage because of the sepsis, or they went for the advanced laparoscopic skills were available, and they went for the laparoscopic cholecystectomy straight away without any prior drainage. So this is the second category of group, and we'll be talking about this a little bit later again. And the last one is where we have the more sick patients. And in this particular one, after the antibiotic supports is given, and where there is no negative predictive factor of organ system failure, and the center is advanced, and there is a good symptom outcome, patients can go for an early laparoscopic cholecystectomy. So that is what is one which is between 0 to 7 days, usually 3 to 7 days in practical hands. But if the patient has got a negative predictive factors for organ system failure, then the patient should be preferably managed by a gallbladder drainage procedure, which could be a cholecystostomy. And then if they are not very good, continue to remain sick, they may be left for observation, or if they are all right, they can go for a delayed or an elective laparoscopic cholecystectomy. So the important point which we want to talk about here is the favorable organ system failure, which actually means cardiovascular or renal organ system, which is rapidly reversible after admission. Many of these patients come with a little bit of sepsis and some pre-renal failure, and these are the patients who can be, resuscitated, and they can be called as the favorable organ system failure. However, if those who do not make a comeback would be classified as the ones which have the unfavorable organ system failure. And then there is the performance status of the patient, which has to be graded as well. Now there is these meta-analysis of 15 trials, including about 1,600 patients, where early cholecystectomy was performed, that is within 7 days of the onset of symptoms, and it showed to us that early surgery did not increase the rate of mortality, bile duct injury, bile leakage, or conversion to open surgery. And this, I would read it with a bit of caution, because there are some other papers which give some different views. We also found in this same study that there was less wound infection, shorter hospital stay, lesser number of working days lost, but of course there was a longer operative time because of the difficulty that they found, especially when they were doing cases between the 3-day to 7-day period. This is another study which is an older one, where when laparoscopic cholecystectomy was just starting, and it was only about 7 years or 10 years, 9 years from when it had started, 530 cases, and 54, there was a comparison between non-inflamed and inflamed, and operative time was definitely longer. There were more adhesions, more blood loss, and the higher incidence of CBD injuries were seen, and also the conversion to open surgery was also higher. But the caveat or the point which we want to make sure in this publication is that this is at least 24 years back, when laparoscopic cholecystectomy was in its nascent stage of training. Even the trainers were getting trained, and the trainees were, not even getting hands-on at that time. Now, this particular study, which came a decade after that, talked about bile duct injuries at laparoscopic cholecystectomy, and is acute cholecystitis a risk factor? So a very big study, 1,568 patients, which were followed up between 1999 to 2003. Classification was done according to the Strasbourg for major bile duct injury, and it was found that complete transaction was seen in 0.3% of the patients, minor injury in 1.2% patients, and similarly, and another later study, which was another 3 years later down the line, another 2,000 plus patients which had 16% acute inflammation. The conversion rate was 5%. Bile duct injury was less than 1%, but definitely it was 3.5 times higher with inflammation, and inflammation was described as an independent predictor of bile duct injury during laparoscopic cholecystectomy. In this more recent study from the World Journal of Surgery, it was found that iatrogenic bile duct injury in the area of Sweden, where this registry was compared between 158 cases and about 600 control cases, the important finding was that mild acute cholecystitis, which corresponds to Tokyo grade 1, did not affect the risk of bile duct injury. And this is a very, very important finding, which I would like to like all the viewers and the trainee surgeons to understand, and those in their early path of their learning curve. In the moderate and the severe, look at the risk. It doubled in the moderate and it became 8-fold in the severe group. So if you are operating on moderate and severe acute cholecystitis, that means more sick patients, then the chances of CBD injury becomes very, very high. And so to summarize, chairpersons, what is the optimal timing? We have moved on from soon after hospital admission, which was the earlier guideline, to those that within 3 days or 72 hours. And now it is felt, according to the 17 randomized controlled trials and 6 meta-analysis and 3 systemic reviews, which were incorporated in the Tokyo guidelines, that the operating time for delayed tends to be shorter than the early cholecystectomy, which we all know because of the degree of difficulty. The incidence of bile duct injury did not differ in this particular comparison done by the Tokyo group. The total number of patients in the meta-analysis was very low, and therefore absence of evidence cannot be taken as evidence of absence of injury. And that is a point which we need to all understand. And early surgery within 24 hours of symptom onset was not superior to early surgery within 72 hours. So that is the short range surgery. And therefore the take home messages from this particular evidence-based presentation: a proper diagnosis and categorization of symptoms as per Tokyo guidelines helps in identifying the complication level of cholecystitis. A proper resuscitation and symptomatic treatment must be ensured. Even if there are benefits to early surgery, this does not mean that urgent surgery after hours should be performed. And ideally, surgery should be performed by surgeons experienced in laparoscopy at a center which is doing high volume of basic and advanced laparoscopic procedures, and the surgeons are very well trained in this type of surgery. So that condition which has been imposed in the Tokyo guidelines has been missed out. It is very important that the people who are doing laparoscopic cholecystectomy in the early phase must be of a very high level of surgical competence in laparoscopic cholecystectomy with a vast number of years under their belt. So with that, thank you very much. And I would be happy to take questions as I would like to mainly to leave for another meeting. Thank you very much for this invitation.
Thank you, Pavninder. It was a wonderful talk and a very lucid talk. You have very well summarized actually the issues involved in cholecystectomy and acute cholecystitis. And I don't see any questions in the chat box, but if any of the chairpersons has any comments or questions, maybe we can just take one or two. And thanks for sticking to time also. Thank you so much.
Thank you, Virender. My only point was that at teaching institutions, normally we are not, doing surgery unless they are in some protocol-based study, and we are mostly sticking ourselves to delayed cholecystectomy at 6 to 8 weeks. And my own experience has been that this is a very comfortable time to do this surgery. Rather than in the initial period. And I personally feel that 72 hours is something that should be a deadline rather than the 72 to 7 day period. And I would like Dr. Rajesh or others to, respond in their own
Yeah,
experience of.
I would tend to agree with you, Pavninder, that actually in the institutions generally what happens is that we are not seeing many mild cases. We are seeing moderate and severe pancreatitis cases, severe acute cholecystitis cases. Actually, that's maybe the reason, one of the reasons that why we are not doing so much early cholecystectomy, and then we have a lot of logistic problems. But I think you summarized it very well that actually lab chole in acute cholecystitis should not be taken lightly, and only surgeons with some experience, with good experience, only should be doing these surgeries. And it is not a run of the mill procedure that you are sitting in a nursing home and you get a patient of acute cholecystitis and you start operating on him. I think the message you gave was very loud and clear. Rajesh, you want to say something, or it's okay, we let go Parvinder?
So, thank you, Pavninder. I think Vrinder is, probing me. So, anyways, the question would be, if we are delaying the surgery, what is the percentage of patients who would come back with recurrent attacks of acute cholecystitis? And if those attacks are severe enough or they have pancreatitis, those are the issues which one has to keep in mind when the timing has to be considered. And I think who else than you can answer this question better?
So I think you have given the answer in your question. The incidence of this is around less than 5%. So 5% of these patients will be at risk of a second attack in the time in which they are waiting for a delayed cholecystectomy. So that risk has to be explained to the patients. But most of the times we tend to, kind of get away because of the large number that you do. The 4 to 5% incidence usually doesn't come in the way. And if it does, those are patients who are giving showers of stones into the common bile duct or something like that. So we are able to manage them with endoscopic procedures for tiding away that crisis. But yes, these are that segment of patient definitely may be a cause of concern. But barring that, I'm sure even in PGI, the experience would be more. I'm not sure whether you are doing early cholecystectomy in PGI. You are not, yeah. So that is why the data will be. This data comes all from the private sector, and all of this is out of our surgery, which is again a red flag raised in the various papers, that it should not be taken lightly. As Dr. Bansal very rightly said, it's not run of the mill. It's a higher degree of difficulty case, and most patients are coming in the difficult period, which is 3 to 7 days. In the first 3 days, it is still okay, but we don't get patients in that catchment time. And 3 to 10 day period is a dangerous time. So, and then they get landing up at odd hour, evening surgery or midnight surgery. And that is when the skill set of the surgeon after a tired long day is not at its peak. And it may not be dealt with by an experienced laparoscopic surgeon as demands of the case. So I think that was the take home. I hope that makes it clear to the people who are here.
I
So
think,
thank you so
Parvinder,
much.
thank you so
Thank you.
much for a wonderful discussion. I would now request Professor Sunil Chumbar to introduce the next speaker. Sir.
Welcome. It's my pleasure to introduce to you Professor Girish Bakshi. He is a professor at the Department of Surgery at Grant's Government Medical College and Sir J.J. Group of Hospitals at Mumbai. And he will be speaking on an unusual topic today, which is, of course, no less dangerous than otherwise. He is speaking on acute abdomen sans pneumoperitoneum. Welcome, Dr. Girish Bakshi.
Thank you, sir. Thank you. Thank you very much. I just want to share my screen, but unfortunately it's not working. Just 1 minute. Actually, I had signed in earlier, but just 1 minute. Can you share? Can you see my screen?
We saw it once, but then it again went
Now
off.
we can't see it.
Can you see it now?
Yes,
Yeah, yes.
yes,
Yes, sir.
it is
Yes.
coming now.
Okay. Am I
Good, sir.
audible and can you see the
Yes.
screen?
Yes, sir. Please, sir.
Yeah, thank you. Thank you. Thank you for the nice introduction, sir. At the outset, I would like to thank the organizing committee of Trauma Conference, especially Professor Subodh Kumar and Professor Amit Gupta, who have been a pioneer in holding this, and obviously the blessings of Professor Mishra. My topic is acute abdomen sans pneumoperitoneum. That is, I'm going to talk about acute abdomen without pneumoperitoneum, that in those cases where there's no pneumoperitoneum. So what I'm going to do is, as you know, abdomen is a Pandora's box. I'm just going to start with definition, causes, and overview of how to manage these patients. What are the important features in their history and clinical examination? What is the role of imaging? And a brief outline of management of the commonest things rather than covering everything. Now, acute abdomen, as you know, is described as sudden severe abdominal pain that is considered a medical emergency, requiring immediate diagnosis and often urgent surgical intervention. When we say urgent surgical intervention, that means these are the patients who are coming to you and forming about 10 to 15% of patients who walk in your emergency casualties. And the causes may vary from inflammatory like appendicitis, pancreatitis, cholecystitis, prominal ulcer has already described, amoebic liver abscess, sealed bowel perforations where there is no pneumoperitoneum in spite of being a bowel perforation, cystitis, pyelonephritis. It could be intestinal obstruction because of pneumoplastic cause, or it could be just mechanical like torsion of ovary or a hernia if you have not stripped the patient till need to see an inguinal hernia. An undescended testis which has undergone torsion again may present to you as acute abdomen, and that is sometime where you have to see the external genitalia. There is, I think, my next speaker is going to talk about that, so I will not be talking about that. Ruptured ectopic pregnancy is very important in females, and that's why we'll be talking the importance of urinary pregnancy test when the patient comes to you, a female patient coming to you in emergency. There are vascular causes of emergency like mesenteric ischemia or ruptured abdominal aortic aneurysm, and this is a real emergency where the patient requires an emergency laparotomy and an emergency OR and the expertise in a tertiary referral center. Traumatic cases we are not going to discuss as this is non-trauma acute abdomen. And at the same time, we should know that there are certain medical causes like pneumonia, acute myocardial infarction, diabetic ketoacidosis, sickle cell crisis, porphyria, which may present as acute abdomen, but they are not actually to be managed surgically. They are basically medical causes of acute abdomen. When we talk about life-threatening causes, we should know that ruptured aortic aneurysm is one of the life-threatening causes, and the patient has reached, that means it is mostly contained, though the patient may be having hypotension. These patients require an emergency vascular consultant for the treatment. Besides this, mechanical bowel obstruction, mesenteric ischemia, hemorrhagic pancreatitis, cholangitis, and ruptured ectopic are other life-threatening causes which will require emergency treatment, an urgent diagnosis, and further management. Now, initial approach if the patient has come to with acute abdomen in unstable condition is always like a ABCD survey, which we all know in trauma. But here the patient C part, that the circulation part may be affected. That's why you have to put two IV fluid, IV peripheral lines and resuscitate the patient with IV fluids. You have to know about his NPO status, NBM status. You may put a nasogastric tube or perurethral catheter if you think that the urine output may be less because the patient is dehydrated or the patient has come to you late. Now, analgesia is something which comes over here, which I have introduced, because before you take history, you have to make the patient comfortable. At the beginning of this century, Cope has told that analgesia should be avoided in the beginning so that your clinical findings are not must. But with the new modern diagnostic techniques, analgesia should be given because it is just going to affect the symptoms. But when you elicit the tenderness, the signs are still there. Now, opioid or non-opioid, that depends upon the cause. Opioid in diffuse and non-opioid NSAIDs you can give in colicky, like diclofenac or something. Now, this is important because after you have settled the patient, his pain has settled, you have stabilized the unstable patient. Pain, we know the mnemonic sitar, that is site, intensity, type, aggravating factors, relieving factors, and radiation. Now, this gives an idea to us where the pain started and whether it has increased in intensity. And if you see the picture, right upper quadrant, you can see that the right lower lobe pneumonia can also present as pain, including liver abscesses, appendix, which is a subhepatic appendix can again result in this. Even the upper pole of right kidney comes over there, so you may have pyelonephritis. Because of that, you may also get pain. Similarly, in epigastric region, you may get the organs involved, especially the pancreatitis. The left upper quadrant again will be having a splenic infarction or a sickle cell crisis or a pyelonephritis. Same thing happens all the quadrants. Depending on the organ which is there, you will get the pain at the beginning over there. Sometimes you may get a central pain which has later on migrated to the right iliac fossa, like classically what we see in appendix. Another thing which we should know is whether the patient is lying still or writhing in pain. A patient who is lying still means peritonitis. That means he doesn't want to move because there is an element of peritonitis, whether it is because of the secondary inflammation of the underlying viscera. That gives an idea to where the pain started. Or if he's writhing in pain, it's a colicky pain. It could be a renal colic or a ureteric colic, which is responsible for this. Now, history carries an important thing because pain is the most important complaint. But with pain, we have to know whether the patient is having any GIT symptoms or the GU symptoms. If we talk about GI symptoms, they can be abdominal distension, vomiting, obstipation, fever, jaundice, hematemesis melena, hematochezia. These are the cardinal symptoms which I'm describing. And in genitouria, it could be dysuria, frequency, hematuria. Leukorrhea in females is essential in pelvic inflammatory disease, and that should be asked for in female patients. Certain things with age are common, like an elderly patient coming to you with pain in the left upper abdomen may be a diverticular disease, whereas a younger patient coming with the right iliac fossa pain may be an appendicitis. In females, in the reproductive age group, you have to rule out pregnancy, ruptured ectopic whenever they come. Besides, this comorbidity, especially in elderly population, has to be taken care of before you go into venture into other details of the patient. In clinical examination, besides knowing the TPR, BP of the patient, it is essential that you look for jaundice, pallor, and lymphadenopathy, and external genitalia, as I told you, that it can be an absent testis, abdominal testis, which has undergone torsion. In clinical examination, here importance comes in how you are going to examine these patients. The inspection, your mind should be clear that you will be looking at distension, whether there's distension, whether the umbilicus is displaced up or down, whether there are previous scars. If you can see visible peristalsis, what is the direction of the peristalsis? And is the abdomen moving with respiration? Because a peritonitis patient will not try to move his abdomen that well. On palpation, tenderness and rebound tenderness give an idea about the underlying peritonitis. You may have a localized tenderness or you may have a generalized tenderness. Similarly, rebound tenderness can be localized, what we see in right iliac fossa and appendicitis, or Murphy sign, what I think my previous speaker has already described. It could be intercostal tenderness like in a liver abscess, or it could be renal tenderness if there is a pyelonephritis. And if pyelonephritis, then we will be knowing that if whether this patient is a diabetic or not. So all these things go like hand in glove. When you talk about guarding, whether it is localized or generalized, and followed by rigidity, which is almost an involuntary response to peritonitis. Percussion, sometimes maybe if you're not able to elicit tenderness or if the patient is not allowing, just a single percussion can tell you about whether there is underlying peritonitis. Auscultation, bowel sounds if presence, if you're seeing hyperperistaltic bowel movements or a silent abdomen. Now here, auscultation has to be done at repeated intervals because a patient who has come to you with hyperperistalsis, after some time the abdomen becomes silent. That means that definitely there is something going on wrong and the pathology is progressing. Per examination is important, like blood and stools in case of intersusception or melena, and per vaginal examination, where you may get a fornical tenderness also in ectopic pregnancy or leukorrhea. Investigation, besides doing the complete blood count, which will show about leukocytosis with the left side deviation of the cell count, going in favor of inflammatory or infective causes, you should do liver profile, renal profile, urine ketones, especially in diabetic patients. Arterial blood gases, especially if you are suspecting that this patient may be having mesenteric ischemia where lactate levels will be required. Urine pregnancy test in all females of reproductive age group. Troponin if you're suspecting myocardial infarction along with ECG. If a patient gives a history of alcoholic binge and pain in the epigastrium radiating to the back, amylase and lipase are worth it. So when you ask for investigations, this is something you are ordering after making some clinical impression after your history and clinical examination. Now, role of imaging has been there, and that is the widespread use where the most important thing is establishing a diagnosis or confirming a diagnosis, which we have already thought about after our clinical examination or hematological profile, and decide further plan of management, whether it is surgical or medical. Now, imaging modalities, we all know it can be right from plain X-rays to ultrasonography to computed tomography, angiography, or magnetic resonance imaging. Now, remember, MRI is not for acute, but still there are certain things which I'll be describing where it has been described in Western literature, not in Indian literature. Now, choice of imaging according to this paper, which was published by American Journal of Radiology, shows that right upper quadrant ultrasonography, left upper quadrant CT, right lower quadrant CT with IV contrast, and left lower quadrant CT with oral as well as IV contrast, and sometimes a parectal contrast, and suprapubic ultrasonography. Now, these are based on their data. However, in our data, it has been, if you see, majority of the patients go through ultrasonography, and if it is not clear, the patient goes to CT scan. But the most important thing is still the X-ray, which we always get it done for all acute abdomens, right from intestinal obstruction to palatic ileus to toxic megacolon. as well as right lower lobe pneumonia, calcific pancreatitis, a patient coming with acute or chronic pancreatitis, or a patient coming to with ureteric colic is very easily diagnosed on plain X-ray abdomen. However, whenever the confirmation of the diagnosis has to be done, or sometimes you are not relied upon, then ultrasonography is useful in diagnosing both appendicitis as well as gallbladder. I'm not going to talk about cholecystitis. I think that my previous speaker has already talked. Target sign, if you see it's a sign of interception in a patient who has come to you with intestinal obstruction. If you're not clear in sonography, if you don't see these signs, then you always have a contrast enhanced computed tomography of the abdomen, where in the recent paper, one of the papers highlighted as CT as the gold standard for acute appendicitis, whereas in our residency, we were told that it will be clinical examination followed by ultrasound, and now it is changing. The target sign, what you are not able to see in ultrasonography, can help you in CT, can be seen in CT scan. And mesenteric ischemia. Now, this is something where if you are seeing a mesenteric ischemia in the same CT, you can, if you have got a program, you can do a CT angiography and recreate the vascular mapping. You can diagnose renal abscesses, acute pancreatitis, and aortic stenosis in patients who are stable and who can undergo a CT, and then you can reconstruct a CT angiography. Angiography more or less for pseudoaneurysms if you have diagnosed on CT. Now, MRI normally for acute abdomen was not been advocated in Indian literature, but there was a paper in Western literature where they say in pregnant females or patients with compromised renal functions or in the pediatric group, they can do MRI in acute abdomens. But the most important thing is after doing all this work of knowing the history and the clinical examination of the patient, correlation among symptoms, signs, biochemical, hematological investigation, and imaging modalities have to be established to confirm the diagnosis and plan further management for optimum outcome. When I say that, I mean that a single symptom or a single investigation cannot be relied upon in isolation. It is the progress of the patient which does. Now, this was a patient who came to us with past history of diarrhea, fever. He was treated by a local general practitioner, and we saw the X-ray is showing just a picture of paralytic ileus. However, the patient's abdomen was not settling after 3 days also. So we got the CT done, and if you see the CT scan, as we go down, majority of the abdomen looks fine. But if you look little bit perseverantly, you can see that there is free air. There are specks of free air on the left side. And that was the site where we were getting localized tenderness and localized guarding. So this patient had an bowel perforation, and that was the reason for his symptoms. So we had to explore this patient. Another patient who came to us with diabetic patient, female, 60-year-old, who had come to us with acute pain in the abdomen. Her right side was completely guarded. There was tenderness and guarding in the pelvis also. And if you see, there's an air fluid level on an X-ray. So obviously, we thought that there's clearly an amoebic liver abscess, and that is it, what it was. But what was more important was that what we were getting was guarding and rigidity in the lower abdomen. We thought that it has ruptured, but what it has ruptured, it was a localized rupture. So this patient, if you see down, this is still going down. Still, the collection is still going down. And if you try to match this collection, it will go right down till the pelvis, with the local bowel loops completely crumpled. Now, in this patient, we try to go surgically, open surgery, it will not be useful. So this patient settled down very well with USG guided, image guided drainage by putting 2 drains, one in the liver and one in the pelvic collection. And that is how this patient settled. So management depends on diagnosis, hemodynamic stability of the patient, availability of resources like ICU, blood bank, OR, expertise. Now, I'm going to talk briefly about the principles of management. Principles are to treat the cause, whether it is surgical or medical, depending upon what cause it is. You have to control the infection if it is the infective cause. If there is localized collections, you drain them, ideally image guided. Minimal access techniques are preferred, but at the same time, emergency laparotomy has to be done in life-threatening condition like a ruptured aortic aneurysm, or where the expertise is not there, or where you're not having a laparoscopic, you may not be having the logistics. Role of antibiotics has been defined in infective cases. It is mostly decided by the respective hospital policy of the infection control committee of that hospital. However, generally, second or third generation cephalosporins are given along with metronidazole. However, we are working in a tertiary referral center, and majority of the times patient is being transferred to us from some other primary or secondary healthcare centers. And then we have to take into account what the previous antibiotics this patient received. The American physicians have given an antibiotic policy both for non-biliary as well as hospital acquired infections. But at the same time, I will say that we have to resort to what we are having and what is our infection control policy. There have been recent guidelines on appendicitis. If you see the WSCS guidelines, they have changed from 2013 to 2016. Again, they changed, and 2020 again they changed, where they said that Alvarado score and the age makes a major significance on the outcome, whether you want to do a laparoscopic appendicectomy or whether you want to conserve this patient. They said that if the patient is having isolated, uncomplicated appendicitis, you can conserve, but if it is complicated or the age is more, then obviously you would like to do a surgery. If the diagnosis is not confirmed, you can do a CT scan and then decide upon surgery. Now, this is just a working plan which they have given. At the same time, this good statement what they have made is it has to be customized depending upon the resources what are available to you and what is the condition of the patient. Laparoscopy is suitable, is feasible in acute appendicitis provided the patient is stable, and then you can go ahead, because even a appendix, a subhepatic appendix can be easily removed. And there was a complete evaluation of the abdominal cavity. You can give good washes also. WSCS guidelines regarding pancreatitis have told that majority of times try to postpone the surgical intervention for more than 4 weeks. In infected pancreatic necrosis, it is good to have a step-up approach where you go percutaneous image guided and then you can go minimal access and then you can do open surgery. Try to go as late as possible to have a better outcome. A multidisciplinary group of experts should be involved in this. Small bowel obstruction, majority of the times it is the mechanical obstruction which requires surgical management. Palatic ileus obviously will be corrected by the treating the underlying cause whatsoever it is. Open surgery is preferred. Laparoscopy has been described, but there are certain challenges like reduced working space, fragility of the dilated bowel loops, difficulty to identify the cause sometimes, and manipulation of the bowel becomes difficult in a distended abdomen. And that's why there is high conversion rate of about 52% if you see the study which has been published. So laparoscopy in SBO has been only advocated if it's a proximal obstruction, bowel distension less than 5 centimeters, and there is a single band or site of obstruction.
Dr. Girish,
the Cochrane review which is there.
Dr. Girish?
Yeah.
I think if you can summarize it a little bit.
Yes, this is. So to summarize history and physical examination, then you can take about whether this peritoneal signs or aortic aneurysm ruptured, and then you can take about emergency surgery. And this is all what I have described depending upon the various quadrants which are involved. However, acute abdomen, which you see in your patients, may require resuscitation if this patient is coming to you in unstable condition. They may require an emergency surgery like a ruptured aortic aneurysm. Investigate stable patient to arrive at a diagnosis. You plan your management, surgical or conservative, and conduct frequent reassessments of the patient. Thank you. I bring greetings from my institute, Grant Medical College. Sorry, the topic was big. I had to cover a lot of things, so I tried to sum up. I hope that the message goes clear.
Thank you, Dr. Girish. You have taught us the whole surgery today in this short discussion. I don't think there are any questions pending in the chat box. And then can I pass on the buck to Dr. Naveen Sharma, my friend?
Dr. Rajesh, can you please introduce Dr. Naveen Sharma?
Thank you, Dr. Bansal. I have the privilege to introduce next speaker, who's Dr. Naveen Sharma. He's a professor in the Department of Surgery at AIIMS, Jodhpur. And Dr. Sharma will be talking on management of non-traumatic genital emergencies, a very difficult topic to deal with. Dr. Sharma, please.
Good evening, chairpersons and friends. There's a lot of people in the panel whom I both admire and respect and love. It's a privilege presenting with this August gathering. So I'll talk about management of non-traumatic genital emergencies, both in men and in women, and I'll studiously avoid the non-traumatic aspects, the traumatic aspects. I'll stick to only the non-traumatic emergencies. So some images have been taken from UpToDate, for which we have a subscription, and no financial interest at all, even though you'll see some images which have some brand names. So what we'll be talking about in this 15 minutes would be a Bartholin cyst abscess occurring in ladies, zipper injury to the prepuce, mostly in boys, intoxicated men, and people who are under care of other people. We'll be talking a bit about paraphimosis, priapism, penile fractures, and then Fourier gangrene, torsion of the testis, which is often confused with epididymoarchitis, and sometimes leading on to piocene. So this is all what we intend to cover in this span. So the Bartholin glands are a pair of glands about size of a pea, which happen to be located at the 4 o'clock and the 8 o'clock position and they are required for some lubrication, even though the removal of them does not lead to any major effects. Sometimes these cysts can get infected and present as abscesses. So the commonsensical thing to do would be to, in case you find such an abscess, you just make a nick out here, and just like a common abscess, we'll deal with it. But there's another way of dealing with it. In case we examine and we find that it is also pointing internally, we can use this SWOD catheter, which is a small catheter which can be inflated. The balloon at the tip can be inflated by about 3 ml of sterile water. And then we can drain the abscess from within the vagina, just outside the hymenal ring. And with a 2 to 3 mm incision only, we can insert this tip of the word catheter and inflate it with saline so that the pus can pass adjacent to the catheter, and we can leave this tip inside the vagina for comfort. And about 3 weeks is what it takes for the whole thing to granulate and heal. In case it does not heal, we might need to go on and perform marsupialization of the cyst. Coming to zipper injuries of the prepuce, usually children who do not wear underwear. So that's been my practice throughout. In case I find somebody in my OPD who has not worn an underwear, I first of all tell them he has to wear an underwear all the time. But even though that is protective, it by no means says that if you wear an underwear, you will not have the prepuce entangled into a zipper. So take care. Wearing an underwear is not a guarantee against having this injury. And the kind of shame that is associated with it, especially in adults, preclude them coming early to it, and they try and get it out in myriad of ways and often aggravating the injury. So the way to go about managing this would be to apply a penile block, which blocks these nerves just off the midline of the dorsum of the penis. And then we also recommend that a kind of ring block near the base should be given, studiously avoiding any adrenaline in this area. Once the pain of the injury goes away, you can apply mineral oil, and a sewing machine oil can suffice for this purpose. And after it's lubricated, you make one attempt at unzipping the zip. And in case it unzips, whatever has happened, and we can take care of whatever damage has been done to the preputial or penile skin. If it does not come off, you have to go to the other option of trying to break the zipper. And so that brings us to the anatomy of a zipper. So the zipper has these interlocking dentitions, an inner faceplate and an outer faceplate connected by this median bar. So what we can try and do for this is we cut the cloth to which the zipper has been attached by the side, and then try to make these transverse incisions. And once these incisions are made, often the zipper just falls through and things are hunky-dory. The other thing people try and do in case that is not successful is to try to break this median bar, which is a lot tougher, especially in the better quality zippers. Thankfully, you don't make too many good quality zippers in the world. So, and the point is that this here would be a penis also, and the person is going to be scared when you're trying to do all this stuff on him. But in case it breaks, it's a good resolution of the problem. Otherwise, some people say that trying to use a screwdriver to lift this outer faceplate up and separate these two also is able to manage the situation. Next, we come to paraphimosis, which can happen in children, which can, as a result of forceful retraction of the prepuce and then letting it lie there forever. And it can also happen in adults. And in adults, the usual cause is that you put in a Foley catheter in a patient who is unconscious, or even then the patient doesn't know that this thing has to be rolled back onto the catheter, and you just let it be there. So the way to reduce paraphimosis is to apply pressure using the thumbs onto the glands and trying to unroll the retracted prepuce back on. So it does lead to a bit of pain, and sometimes you might be better off giving a ring block before you do it. Since this was not too bad or too prolonged, we just did it without anesthesia. In case it is refractory, you might need to do a dorsal slit. Coming on to priapism, the definition states that an erection which is lasting more than 4 hours without sexual stimulation is what is the definition of a priapism, and we don't really wait for too long before we intervene, but sometimes just patients come in a little later for us. So in case a patient has come to us, the people suggest that you try and differentiate between an ischemic priapism versus non-ischemic priapism. I say it is more difficult because we don't have too much experience of it, and we assume that the worst, that it is an ischemic priapism, and we manage accordingly to try to judge whether the erection is really very, very rigid or not. It takes a lot of effort and brains. I would strongly suggest it's much easier to simply aspirate the blood out of the corpora cavernosa, putting a needle either through the shaft of the penis or through the glans penis, and then send it off for blood gases. The blood gases analysis is going to tell us whether it was ischemic. Also, the kind of blood that we aspirate, whether it is bright red blood or dark colored blood, would also suggest to us whether we are dealing with an ischemic priapism or a non-ischemic one. And ischemic priapism is a very, very severe emergency. So after aspiration, we inject phenylephrine, 300 to 500 micrograms every 3 to 5 minutes. And usually we try to dilute the phenylephrine, and we must ensure that we understand the dosage of the phenylephrine in the bottle that we are using. It comes in various concentrations. This one to demonstrate is a 1 milligram per ml. You also get doses of 110 milligrams per ml. So be careful that you try and reconstitute it for about 500 micrograms in a ml, and then we inject it every 3 to 5 minutes till we achieve detumescence. In case it still doesn't go down, we need to perform a distal arteriovenous shunt, a T shunt, which sounds a little more complex than it actually is. The whole thing that needs to be done is to put in an 11 number blade far away from the urethra, and we make a stab incision with the 11 number blade going through the glans penis and going into the corpora cavernosa. And from that, we milk out the whole blood from the penis. And then at the end, once we have achieved detumescence, we suture the glans incision. The key thing is, after we go in with the 11 number blade, that blade is turned outwards, away from the urethra, to make it a form of T. That creates the arteriovenous shunt distally, and it is usually quite helpful in getting things done. Sometimes these fistulae need to be dilated. There are pretty good videos, teaching videos available on YouTube, and I'm sure we can access this in case we are interested. The next thing we're talking about is a penile fracture, and the history is very characteristic that even though our patients seem to deny it, the usual, if we probe deeply, you'll find that the patient was having a raging erection, he was having sex, and then during that act, the penis comes out, and then it strikes either the perineum or pubic bone or something. It is more associated with the woman on top position, and there's a characteristic crackling sound that happens, and then it goes down, it becomes flaccid, followed by this appearance of this impressive blue dark blood which seeps all through. So the reason why this happens is because this tunica albuginea, which surrounds the corpora cavernosa, gets torn, and usually the site of tear is proximally near the penoscrotal junction. And I'm sure all of us have experienced a lot of cock and bull stories. People bending in bed, people walking, climbing a train with a raging erection and then hitting the door or something. Everything but coitus is implicated in the etiology according to our patients. But once we get down to telling them that we understand what's going on, they come out with the truth. And ultrasound is helpful to find out where the tear is, and that can help us in deciding the incision. If in case it is at the characteristic location near the penoscrotal junction, we can just make a penoscrotal incision instead of a degloving incision, which also has to be followed up by this circumcision. So we just follow the hematoma, and it will lead you to the breach in the tunica albuginea. And suture choices vary from 3O polygalactine to 2O PDS. Different authors prefer different kind of repairs, but something which is absorbable early is perhaps possible. Better, my choice remains polygalactin. The next topic is a Fourier gangrene, and I'm sure all of us have seen. It's a necrotizing acute soft tissue infection involving the scrotum, more in diabetics, and there's no rocket science involved. Once you're dealing with necrotizing soft tissue infection, you debride, and you debride liberally. The good thing is that the testes are usually healthy, and debridements can be extensive, but testes tend to be healthy, and at a later point in time, you can have testes which are kind of entrapped in tissue sometimes, and then you might need to do some procedures to reposit them back and see how things go. Now I'll come to the scrotal anatomy and classical MBBS and MS questions about the layers of the scrotum, and there's a lot of layers. We need to be aware that scrotum is a hair-bearing area, and all infections can happen here. There can be sebaceous cysts which can get infected. And apart from that, on the deeper things, we need to be aware of what testicular anatomy is like, and the tunica vaginalis covers the testis in front. At the back, there is the epididymis, and we'll come to the appendix of the testis at a later point in time. This is important, the attachment, how exactly the tunica vaginalis envelopes the testicle is important, because in case it goes up for a variable distance on the cord, and the testis is lying horizontally, this predisposes the testicle. This is called a bell clapper deformity, and it predisposes the testicle to a torsion testis. So once it gets torted, the possibility of ischemic insult depends upon how many turns the cord has taken, and the torsion can be both of the cord. That means the entire cord has rotated, which happens mostly in the neonatal age group. And in the prepubescent age group, the more common etiology is an intravaginal torsion testis. And then these are all the appendix of the epididymis of the testis, and then other appendages which are described in relation to the testis. And these can also undergo torsion. And classically described blue dot sign, which happens in about 20% of patients, is classically described, but please don't expect to see it in the black colored scrotum of our Indian patients. So time is money here, and most people now want to get an ultrasound and a Doppler. But be aware that a Doppler which shows that there is flow to the testicle does not rule out a torsion of the testis. And in case we try and do a clinical examination, we might find Francine, which is trying to differentiate between an acute epidydmoacitis versus testicular torsion. In case you lift up the testicle, the pain is supposed to decrease in epidydmoacitis, but not in torsion testis, but it has pitfalls and it's not foolproof. If you're not sure, go ahead, explore. And in case you feel like in busy public hospitals that you're not going to be able to get the OT within the next 2 hours or so, consider a manual derotation. And the derotation, classically teaching, we tend to do it outwards. That is, we take our hands. If you're sitting in front of the patient, we do it outwards. But some studies have also shown that this classical outward rotation could be fallacious in some instances, and we might be better off trying to look for the result. In case the pain disappears after an attempt at detorsion, we think that things are better, but in case the pain has not gone away after doing this outward rotation, take it with a pinch of salt. You have failed, and try and explore as soon as possible. Even in case this procedure is successful, you have to go ahead with the surgery and trying to fix it up. Do ensure that you open the tunica vaginalis and fix the testis. I see a lot of people who have not even opened up the tunica vaginalis, so there's no way to take the sutures to the tunica albuginea of the testis without actually opening it up and guaranteeing it. We won't go into the blood testis barrier and how it is by taking these sutures. Some people take absorbable sutures, some people take non-absorbable sutures. A good marriage might be a PDS, which lasts long enough, but not forever, so that can be prevented. And please don't forget the opposite side testis, you have to fix it. In case you have forgotten to fix it and that other testis also undergoes torsion, you are exposing yourself to a big medical legal risk. Epididymococcitis is a differential to the testicular torsion, and I see a lot of people who diagnose epididymococcitis more often than they should. The incidence of torsion is pretty high. So rule out testicular torsion. If you've ruled it out, then you entertain this diagnosis. So usually scrotal support, antibiotics, and NSAIDs. Sometimes this can progress on to an abscess. This can also give rise to a mild hydrocele, which also can get infected, leading on to perhaps a piocele, which would need a formal drainage followed by antibiotics. Thank you so much. I hope I've kept time.
Yeah, thank you, Naveen, for a very lucid and concise talk on common surgical non-traumatic scrotal emergencies. I think you summarized it very well. I don't see any questions in the panel, so I think the organizers are also short of time. So I think we can conclude this session here. I would like to thank Dr. Naveen, Dr. Pavninder Lal, and Dr. Girish for their wonderful talks, and my co-chairpersons, Professor Sunil Chamber, Dr. Rana A.K. Singh, and Dr. Rajesh Gupta for chairing the session with me. Thank you so much.
Thank you very much.
Thank you very much to all two respected speakers and chairperson. It was our privilege to have all the dignitaries here, and have a nice day ahead. And we would like to see you soon. Thank you very much.